Can you just find out how many of you are PD specialist nurses? Anyone in the audience? No one. All right. Switching the talk on the on the PD specialist nurses. Any neurologists? Psychiatrist? You're a neuropsychiatrist. Any neuropsychiatrists? Psychologists? OTs? Physio? Secretaries? Have we missed anybody? Any professionals? Apart from this, okay. Oh, sorry. Nursing? Yeah. Social workers, sorry. It's quite an eclectic audience. I really can't. There may be some of you who know everything about what I'm going to talk, so please bear with me. Hopefully, some of you will take some information home, and the main idea of the whole workshop is to get some awareness into this. I would say this new emerging topic, but it's been around for more than 10 years as a concept, and there's a lot of research that's gone on into the non-motor symptoms of Parkinson's in the last 5 years, certainly. The objectives of the session is just to get an overview of what the non-motor symptoms are in Parkinson's disease, why do they matter, and why should we know about them, and how to recognize and objectively assess them, and how to manage the NMSPD. Obviously, I can't go into the management of each and every, there are about 40 different symptoms, so I can't really go into each and every one of them. So hopefully I can give you some overview. We'll start off with some cases, just to give you an idea as to what kind of patients get referred to neuropsychiatry and what we do with those referrals and how we manage the problems. If you have to stop me, do interrupt. If you want to ask any questions, do so, and keep it interactive as much as we can. Some of the slides haven't come out okay, so you may not be able to see it properly. So if you can't see it, I do apologize, and I can email them to you later on if you want. This gentleman who is currently in our ward at the moment, I've obviously changed the name and changed some of the details to make it anonymous. A 58-year-old gentleman, 7-year history of Parkinson's disease, on levodopa and dopamine agonists. It's got 12-month history of behavioral disturbance, being very restless, agitated, not sleeping, not eating well. And more recently, in the last 6 months or so, he's beginning to have delusions and hallucinations. He believes God is talking to him. His family have seen him having a conversation. The nursing staff have seen him having a conversation, and he actually has seen God. So it's both visual and auditory hallucinations, and also delusions. Not grandiose, but he's not disturbed by it either, but he's got these thoughts and perceptions. He was admitted following a couple of incidents when he was on the rooftop looking for Rihanna. That's how he was referred and admitted to Harplands. He's been with us for a few months now, and Dr. Mann is a neurologist who's involved in his care, and we're doing some changes in the treatment. I just want to know about this case and the 2 other cases, and then as we go through the discussions of non-motor symptoms and the management, we can come back and relate to how we can manage John. Second is Liam, 67-year-old married man. He's got a 15-year history of PD, quite a long history on dopamine agonists for several years, but the dose was increased recently, just a few months ago. And according to his wife, since the dose was increased, although I don't think it is a case. I mean, he's had these problems for a number of months, but I think certainly the increase in the dose has made it more obvious. Spending hours in the computer at night, he's got massive addiction. He goes into his garage and he organizes all these records into different boxes and labels them, and he's so obsessive about and ritualistic about this collection. But more importantly, his wife complains that he's sexually very disinhibited. He masturbates in public areas in the house, and he doesn't bother who's there. Demanding sex from wife all the time, and this has caused a lot of marital problems, obviously. He's been managed in the outpatients clinic. So John with more of psychotic symptoms, Liam with more of obsessions and ritualistic behaviors. A 50-year-old married woman, Kelly, 6 months history of jerky movements, more myoclonic type of jerks, some tremors occasionally, some dystonia, but not very obvious, gait disturbance and recurrent falls, especially in the mornings when she gets up from bed. But the main problem with her is low mood, severe low mood, diagnosed with major depression, has been seeing GP and been on SSRIs for 6 months. The husband says that he's now sleeping in another room because he can't sleep in the same bed. She's extremely disturbed throughout the night, wakes up a number of times. She's got vivid dreams, shouts, screams, kicks him, given him black eyes a number of times, and causes a lot of bruising. And she's also destroyed the things on the side table in the bedroom. So he's just left a bed, no furniture otherwise. She can be very violent during the night time. So Johnny with psychosis, more of psychotic symptoms. Liam with sort of ritualistic behaviors, and Kelly with more of sleep disturbance. These are the kind of people we get, and Kelly is probably more in the. She's not been diagnosed with PD yet. I think clinically it looks like it. She's just gone for a TAP scan, but it looks like she's got PD. Okay. Parkinson's disease has been well-known condition ever since James Parkinson described it. More of a shaking palsy. Charcot is was someone else who described it as well very well. But going back into the 10th century BC, it's been described in ancient Indian Ayurvedic texts about this kampa vata, which is just basically means in Sanskrit as shaking palsy. Not only physical problems, motor problems, they also describe a problem of mind and body, and emphasis has been laid on the gastrointestinal tract. They believe at that time that it was mainly from the gut. The problem started from the GIT. So interesting that the modern research, the contemporary research also points towards more of gut problem as gut etiology as one of the main factors. They also, 2 centuries later, 8th, 7th century, the Ayurvedic text also describes treatment for it from a plant seeds of 2 different colors, white and black, mucuna puriens. And interestingly, the active ingredient is levodopa. I don't think they knew about it, but it's just one of those things that was used, and it brought some relief to the motor symptoms. As James Parkinson's description, a paper in 1817. It's a progressive condition. Progressively gets worse, and motor symptoms are predominant symptoms, and people get referred to neurologists with the onset of motor symptoms. It starts with unilateral presentation, but it's a generalized condition. But sometimes tremors and dyskinesia can be more prominent on one side, and it gets worse as we go. It's the UK Parkinson's Disease Society Brain Bank criteria is used for diagnosis of Parkinson's clinically. Most importantly, have to have bradykinesia of some form, slowness of initiation of movement, reducing the speed and amplitude of repetition, and at least one of the following: muscular rigidity and postural problems. There are some exclusion criteria. It should not be any infections, head injury, and so on. Starts with usually a unilateral onset, but it can be generalized as the condition progresses. That's where people usually get referred with motor symptoms to neurologists, but it's a progressively worsening condition. But if you look back, this is what we know now. as a prodrome, that problems start years ahead, as we see in Huntington's, as we see in other degenerative conditions. Now, non-motor symptoms. Non-motor symptoms, I should thank both Professor Kavanagh and Dr. Chowdhury for sharing some of the slides, for allowing me to use some of the slides. So I've acknowledged as I go along. And there's been a number of studies done on non-motor symptoms, usually starting from early 2000, 2001, 2002. But this is a comprehensive assessment on non-motor symptoms, more structural assessment, and from this started much more objective assessment of the non-motor symptoms, developing scales, etc. These are the different kind of symptoms you can have in Parkinson's, which are non-motor. I tried to group it as much as I can into broader categories. As you can see, the neuropsychiatry symptoms are something that we are very familiar with in neuropsychiatry. People get referred. These can be prodrome, starting many years before the onset of the motor symptoms, pre-manifest stage. Delusions, depression, obsessional behavior can predate, and they may not be necessarily treatment related, but they can be more prominent once you start treatment for the Parkinson's disease. But most importantly, REM behavior disorder. This has been repeatedly shown as a significant problem and in pre-manifest stage. Restless leg syndrome, periodic limb movements, not so strongly associated, but do happen. This, in reference to Kelly, the young lady who was referred a few months ago with problems with insomnia and severe sort of REM behavior problems. I think she's also referred to sleep clinic. She's undergoing sleep studies, but I suspect that it's probably more of a REM behavior disorder related to PD. It can have autonomic symptoms. Bladder disturbances are reported. Orthostatic hypotension and most of postural hypotension and hypertension on lying down has been reported. Sexual dysfunction, hypersexuality, erectile impotence as a drug-naive patients report problems there. But once you start with dopaminergic agents, people do have hypersexuality. Now, this is an interesting area. Again, constipation, along with depression and behavior disorder, have been shown to be happening many, many years before the actual onset of motor symptoms. So much so that people are even thinking that this is something that would need to be routinely assessed as part of as a clinical marker for onset of the Parkinson's disease. So I want you to remember about constipation, depression, REM behavior disorder, and loss of smell. I haven't put it there, but loss of smell is something, olfactory disturbance, that's there. So 4 problems as predating motor manifestations by several years. This is a kind of a prevalence. There are about 3 or 4 prevalence studies which are really good, which people have systematically analyzed the incidence of and prevalence of the non-motor symptoms. And as you can see, I just put it there to highlight the percentages. Depression, 50%. Fatigue, 58%. GI symptoms, 52%. Constipation is it's very low in this, but it's actually shown to be very common. Sexual disturbance, and then cognitive problems. Cognitive problems, dementia, is much more common and inevitable, according to the Sydney group who did the 20-year follow-up, that dementia is inevitable towards the end stage of PD. But you get mild cognitive impairment, dysexecutive syndrome type of problems quite early on. This study looks at most of the onset. How far can we go back to say what kind of problems do happen at what stage. This essentially shows a very drug-naive patients in PD. NMS is common, non-motor symptoms are very common, and that a majority of the non-motor symptoms occur frequently in patients than in controls before the onset of the motor symptoms, well in advance. And certain non-motor symptoms in their combination allow discriminating Parkinson's disease from controls, even when occurring before the motor symptoms. There were different kind of subgroups. Some were mild, some were quite severe. Pain, sleep disturbance, constipation, these are quite severe. Depression can be quite severe as well. And again, this is giving a kind of subgroup based on the different types of symptoms that are predominant. If you can see the first one, 96% loss of smell. Constipation is quite high. Mood disturbance, attentional problems, frontal lobe, and some autonomic symptoms as well, quite common. These all, this is an interesting staging done by Brock, published in early 2000, where he says that there is a caudal-rostral progression of the pathology in Parkinson's disease. The olfactory bulb and the medulla gets affected first, and then it progresses towards the other brain structure and then spreads to cortical areas. And he postulates that because of this progression, the loss of smell, and GI symptoms through the vagal nerves, nuclei, or more, they happen quite in advance and many years, several years before the onset of the motor symptoms and cognitive symptoms. I think there have been few studies which have replicated this, but there are some studies which really have a different hypothesis on the onset and the progression of the symptoms. But it's interesting, and it's been well established concept in the progression of Parkinson's disease. So this is another picture of the same. There are 6 stages for stage 1, 2, 3, 4, 5, 6. First stage, as I said, olfactory bulb gets affected, and then the vagal nerve nuclei, and then it spreads through the brainstem upwards towards the basal ganglion structures, substantia nigra, nigrostriatal areas, and finally in the late stage gets the cortex involved, and that's when you develop all the severe cognitive symptoms. These are all Lewy body deposits, by the way. So if you look at the non-motor symptoms, and if you look at their presentation, you can get several up to 20 years before the onset of the motor symptoms, up until the end, up until the death. So it just spans the whole of the Parkinson's stage. The premotor stage is gaining more importance, and that's for a number of reasons, as we'll see in the next few slides. There are 4 distinct non-motor symptoms of PD, as I mentioned before, that I want you to remember. There's olfactory problems, sleep problems, REM behavior disorder, constipation, some refer to as obstipation, is obstructive, very severe, impacted infection, depression. These are very common non-motor symptoms. As I mentioned before, the Sydney multicentric study concludes that in PD, dementia is inevitable. As you progress, as you go along, dementia is inevitable. One of the hypotheses of not just non-motor symptoms, but also as Parkinson's, the infective hypothesis has been around for some time, and it gained prominence in the 60s, I think, in the 80s, sorry, by this duo, Poskanzer and Schwab, who challenged the whole world that if they find any new onset of Parkinson's disease after 1931, fully established Parkinson's disease, a new onset after 1931, they'll give away a bottle of scotch. After giving away 14 bottles, they decided, enough is enough. their theory was that Parkinson's disease is an infective condition caused by influenza virus, and by 1980, Parkinson's disease will be completely eradicated. And they're quite, but it's been dismissed. It came as a very important time article in Time magazine at the time called Parkinson Puzzle. If you Google it, you'll be able to see that. But Hawk and Brack, who also talked about the viral etiology, they talk about dual hit hypothesis. On one hand, they say that the viral neurotropic agent goes on from the nasal passage up to the temporal lobes, infecting along the way, and a retrograde progression from the Mason's plexus and vagal neurons in the medulla upwards, so a dual hit hypothesis. There's a neuroendocrine hypothesis involving dopamine melatonin imbalance has all been postulated, and there's been some studies supporting this because of the sleep problems and other things. Now, the second question of the talk. So we know a little bit about what the non-motor symptoms are. What are the four main non-motor symptoms that can predate the motor symptoms? We know them, but why do they matter? Why should we know about them? Can we not just treat it as they come along and just focus on the motor problems as we've always been doing? The PD Life study is an observational study which talks about quality of life. And they've shown, and a number of studies after that has repeatedly shown that the quality of life is affected extremely in patients who have severe non-motor problems. And if they're untreated, and the disease burden and the problems gets worse. So it matters for quality of life and the prognosis of the condition. So we should know about them, and whether we should treat them or not is something that we'll talk about towards the final half of the talk. And it appears to be the key determinant in all of the quality of life assessments. Now, the quality of life can be affected both because of the Parkinson's disease symptoms directly, the non-motor symptoms, or indirectly because of the pain, insomnia, not able to work, behavioral problems, marital problems, and so on. They can cause a lot of psychosocial problems as well. So indirectly, they can affect them. Now, the key aspects are, according to Martin and Professor Chowdhury in the validation group, the key problems are sleep, fatigue, mood, and apathy. So these have a direct impact on the quality of life. Now, this is the first of the PD Life study showed that it's got a major implication on the cost. The amount of the cost for the healthcare in terms of treating PD. If you focus just on the motor symptoms and ignore non-motor symptoms, it's going to be more expensive as the disease progresses. So it's got major implication on the cost of the care overall. It also matters because now in this one, if you look at this slide, what we can see, the number of studies have repeatedly shown that hyposmia, olfactory disturbance, increases risk of PD by 10 times. Rapid eye movement disorder, 40% risk of developing synucleopathy. Constipation, depression, these have been consistently shown to increase the risk of PD. There's no direct link, but these have been consistently shown as something that happened in premotor PD retrospective studies. Now, if you are able to detect these things early on, and if you know that they're going to affect the quality of life once they're being diagnosed, you can do something about them. So that's why it matters. It also matters because if any of these can be studied further and confirmed that they can be clinical biomarkers, along with other biomarkers which are being studied as we speak, then a day may come when you have disease-modifying agents which are very effective. And if you're going to diagnose somebody at risk group, 20 years ahead of their onset of the motor symptoms, and you can do something about it to modify and change the disease, I think it's well worth it. I don't think we've got any confirmatory biomarkers just as yet, but anybody in the audience may know about that. But as far as I know, none. But a smell test is being used increasingly as a kind of a premotor diagnostic tool. slides, I think. Skip that. Just a few minutes on the specific conditions. This is what we see in neuropsychiatry when neurologists, PD specialist nurses, or GPs refer patients to us, and psychiatrists. This is what they refer them to us, managing depression, anxiety, psychosis, cognitive problems, behavioral disturbance, and so on. There are some interesting aspects of the neuropsychiatric manifestations in PD, some of which may be as a part of the disease itself. They share the common pathology. Some may be iatrogenic treatment-induced problems because of the dopaminergic agents. But depression has been thoroughly, very well studied in Parkinson's disease, both in the pre-manifest stage and throughout the disease. And the dysfunction of dopaminergic serotonergic system, norepinephrine system has been implicated in the pathogenesis of the PD. That's why sometimes dopamine agonists, they are very effective in the early stages of Parkinson's disease when people have got low mood. SSRIs have been used, but they can bring about some of the sort of behavioral problems at some stages in Parkinson's disease. Deep brain stimulation has been shown to be effective as well, and non-pharmacological measures like cognitive behavioral therapy has been used in depression, but more importantly in impulse control disorders. But it's been shown to be effective in depression and anxiety. Psychosis. As a drug-naive patient, people who have never had Parkinson's disease treatment, people who have just been diagnosed, can still have hallucinations, delusions, etc. But as we have seen in John, the first patient that we saw, who is in our ward, treatment, especially with dopamine agonist, can precipitate hallucinations and psychotic symptoms. Basically, the D3 receptors are occupied by the dopamine agonist. D3 receptors are implicated in the formation of psychosis. So, dopamine agonist treatment can bring on severe psychosis. How do we treat them? I would probably say start with reducing the agonist. If you use anticholinergics, that should be the first one to reduce or stop. But try and reduce the dopamine agonist. It's an emerging concept called DAWS, dopamine agonist withdrawal syndrome. So you got to be mindful of when you reduce it very slowly. That would be the first step. But specific antipsychotics are used, and you have to use it very cautiously, probably under supervision, so as not to any antipsychotics you use are going to make the movement, motor problems worse. So you've got to be very careful. Dementia. 40% of people do end up getting dementia. In fact, the Sydney group says, it is 100%. Everybody will get dementia if they don't die before for other reasons, so they will eventually become demented. The major neuropsychological features, the dysexecutive syndrome, these can predate, as I mentioned before, can happen many, many years ago. Although Brock's stage 5 and 6 says the cortical involvement at a very late stage, we know that frontal lobe problems, dysexecutive syndrome, can happen early as well, especially inattention and so on. The management of dementia involved a multidisciplinary approach, excluding all the other physical causes. Make these simple things better. People have pain, sleep problems, constipation. Improving these things matters. But specific treatments are used. Rivastigmine is what I personally use anecdotally, but I think there is some evidence to say rivastigmine is probably better suited than the other cholinesterase inhibitors. Now, the sleep is of the 4 important non-motor symptoms that I said, sleep is an important thing to know about, especially REM behavior disorder, as Kelly, our patient, had. Can be vivid dreams, disturbed sleep fragmentation, not so much of early morning wakening as you see in depression, but more of disturbed sleep throughout, and loss of muscle atonia is the reason that they behave a certain way they do. Daytime sleepiness, excessive daytime sleepiness has been known as well. Some people with PD do have restless leg syndrome associated with low ferritin levels, and treating correcting the ferritin can improve the symptoms. But RBD is successfully treated with clonazepam, very effective drug. Could not be used if they have sleep apnea. Got to be mindful of that. But sleep disturbance, improving that will have a huge effect on the quality of life in the overall prognosis of the condition. So it's something that to bear in mind. Autonomic dysfunction. Two important things. One is bladder control, loss of bladder control quite early in the condition, hypotension, orthostatic hypotension, having falls. Kelly, the last patient we saw, had repeated falls. I think there is some gait disturbance as well contributing to it, but most importantly, I think she has got postural hypotension, quite severe in the morning as soon as she gets up, and also increase in blood pressure lying down. Simple measures would help. Raising the pillow by 10 to 30 centimeters. Some elderly people can't cope with this. They slide down the bed and it's not practical. Wearing severe tight stockings and light bristles have been trialed now. Compression stockings and bandages help. Increased salt in the diet help. Just simply drinking water has been shown to be very effective to increase the blood pressure. Not salt water, just plain, not warm water. Warm water did not, they tried injecting water intravenously, did not help, but simply drinking water helps. It's got 5 minutes, I'll just have to rush through. Now, coming to the last part of the non-motor symptoms. So we know what they are, broadly speaking. 4 important non-motor symptoms. Why we should know about them, because they have a huge impact on the quality of life, the overall prognosis, huge cost savings, economically important as well. So, but how do we approach them and how do we assess them? I don't want to go through each and every list here, but there are 2 important scales that's been used: NMS Quest, non-motor symptom questionnaire, and the NMS Quest and NMSS is a non-motor symptom scale by Professor Chowdhury. There is a revised UPDRS score as well, which can be used, but NMS Quest is the most commonly used one, I think. It's easily, it takes about 10-15 minutes to do it in the outpatient's clinic, and it's fairly easy to do and gives a lot of information. Now, obviously, this is in addition to, this is more of an objective assessment in addition to the history and assessing the patient in general in the traditional way. But it's more objective, both in terms of finding the NMS and also following for treatment. Now, once you know that these are there and you have objectively identified them, how do you treat them? There's a lot of therapeutic nihilism. I think even among psychiatrists, if there is a neurological problem, they are very reluctant to treat the patient, especially Parkinson's symptoms. We don't know how to approach, what to give, whether the motor symptoms will get worse. I think that's where working with a neurologist, Parkinson's nurses, is quite important. I think most of the Parkinson's nurses do copy the letters to us, and we call us and discuss if there's any problem. So working jointly with neurologists is important, and I think the non-motor symptoms have to be identified early on, and they should be treated. There should not be any question about it. But you've got to be careful, and you've got to have a proper approach to it. This slide doesn't come out very well, but just to give you an idea about excessive daytime sleepiness, simple measures like caffeine has been postulated. Let's look at the REM behavior disorder. I think clonazepam is very useful in that. Melatonin has been studied. Pramipexole in combination with clonazepam in one successful trial. I'm not sure about that, but that's been postulated. Depression, some studies say mirtazapine is very effective, but I would go with simple SSRIs as we normally do with with citalopram and drugs like that. Avoid tricyclics as much as you can. Modafinil, I've used one patient with alexithymia and severe apathy, modafinil, and he was from Shropshire, and I haven't seen him for the last 2 years, but he showed a good response to it on modafinil. Pain, simple measures. Pain affects sleep. Sleep, they can feed to each other problems, so you have to be very careful about pain and treating the different hypotheses for the pain, how they develop in Parkinson's. And I may have a slide on it, but I don't think I have time to go into it. But it's important treatment, non-motor symptom to treat as well. But if you look at constipation, just simply treating constipation by diet, simple commonsensical approach makes a huge difference. So that's something that you got to bear in mind. And just treat it when you can. So this is kind of an approach that's been suggested by Professor Chowdhury, how you normally approach non-motor symptoms in the clinic. Some kind of practical approach. What do you do? The patient comes in, given the NMS questionnaire, then the healthcare professional grades and scores them. Depending on the severity of the score, they then make decisions about whether to treat them there or whether to refer them on to any other specialty, depending on the group of the symptoms they have. Pharmacological therapy, other therapies can be arranged as soon as possible. Multidisciplinary team work, working closely with neuropsychiatrist and neuropsychiatry team. Some support from other specialities, especially sleep physician. We do have a sleep clinic here, and we can have sleep studies done locally. This is a good, Professor Kwana is here. It's a good, you can get a good overview of the non-motor symptoms and generally about the basal ganglia disorders and how the neuropsychiatric manifestation of basal ganglia disorders in this paper. Now, I don't think I have enough time to talk about impulse control disorder, but this is a treatment-induced conditions, iatrogenic conditions, especially more common in dopamine agonist, less common in levodopa and other drugs, but very common in dopamine agonist. Ropinirole, commonly implicated. As I said before, the D3 receptors are implicated in the pathogenesis of psychosis, and the ropinirole has a strong binding to the ventral striatum. The D3 receptors are there, and they lead on to the impulse control disorders. They're quite broad condition where people have very compulsive behaviors. They do things like compulsive gambling, hypersexuality, sexual addiction, increased food intake, and so on. Can't go into that. Just give you a diagrammatic representation of that impulse control disorder. The clinical manifestations, can occur pre-morbidly. There are some characteristics where people of young age, male preponderance, people with past history of cigarette smoking, family history of gambling, and some kind of drug and alcohol taking, increasing risk of impulse control disorder in PD. Male, as I said before, young age. Males have more of hypersexual behavior. Females demonstrate more of excessive eating, binge eating, and compulsive shopping. Clinically, all these drugs are implicated with more of dopaminergic agents. There are specific questionnaires developed by Weintraub for ICD. I won't go into that. Easy to screen impulse control disorder in PD. 20% of the newly diagnosed patients report that, so you've got to know about it. It's important and easy to find out as well. Unless you ask, you're not going to get these symptoms from patients. There's another group of symptoms called, I'll have to go through quickly that. Valerie Woon has done a lot of work on the impulse control disorder, especially sexualized behaviors, and some questionnaires she's developed, I think, on hypersexuality. Funding is a behavior where I think Liam, who had this record collection, goes into the garage and he'll sit there for hours trying to organize all these things. It's called funding, and it's a ritualistic behavior. It's a type of, it's again academic and treatment-induced condition. I'll just look at the treatment for impulse control disorder. Very simple to do. Reduce the agent, offending agent. Let the patient know what it's about and what they are. Giving information helps. And consider switching from oral to other forms of, you can try the patch or continuous apomorphine and other methods of treating the motor symptoms. CBT. CBT is increasingly used in all sorts of non-motor symptoms, but more importantly, has been shown to be effective in impulse control behavior. So I'll stop with that.